So if we circle back to the case, and then I'll go to questions after that. In this patient that is 31 weeks pregnant, who presented with more frequent headaches, who previously had headaches before the pregnancy, stopped her Diamox. What should happen with this pregnancy is she should be put back on Diamox, okay? So if this patient was sent to me, I would restart her on Diamox. I would start her at the dose that was last effective for her. You know, some clinicians like, well, I don't know where to start. Do I start at the minimal dose or do I start at the highest dose? You start at the last effective dose and then titrate up from there. Let's say a patient is on her last effective dose and it's not working. There's a couple reasons that may be the case. One, the blood doubles in the pregnancy, blood volume doubles in the pregnancy. And so heart function is working more in the pregnancy, and you have more circulation of blood during the pregnancy. And so it's almost like putting a drop of dye into a cup versus a drop of dye into like a gallon bucket. Obviously, red dye in a cup may look like sort of dark pink. Red dye, that same amount of red dye in a gallon is going to look, super light pink, right? It's more diluted. Same thing with certain medicines in pregnancy. You are diluting the drug. So it's very common for us to have to go up on the medication doses during the pregnancy to get the same relief of the headache. This patient also needs every trimester eye exams. So she needs opto eye exams through an ophthalmologist to look for evidence of papilledema, to look at the back of the retina, retinopathy, and to look for signs of decreased visual acuity. We'll also center for co-management with a neurologist, which is a doctor that treats headaches, so that we can get her on the right regimen. And if a patient does need breakthrough pain medicine like a narcotic, I would want that managed with a neurologist, if possible, so that we can make sure that we're treating the patient on the right amount of stuff. I know some people have asked me, said, hey, I was on Toradol before pregnancy. Can I take that with IIH during pregnancy? I would caution against something like Toradol. Toradol is an NSAID, a non-steroidal anti-inflammatory. There is a role for NSAIDs in IIH, but that role is just patchwork, right? It's decreasing inflammation, yes, but it doesn't decrease the intracranial pressure. So it's not going to give us much relief as something like acetazolamide. And so I would recommend that over something like a Toradol or an NSAID. Additionally, NSAIDs in the third trimester should be used with caution. They can inadvertently close one of the shunts in the baby's heart called the patent ductus arteriosus. Closure of that prematurely can lead to pulmonary hypertension or high blood pressure in the lungs of the baby. That can be life-threatening and also have some long-term complications. So we do not like to use Motrins or Toradol or Tramadols in pregnancy if we can avoid them, especially beyond the 32nd week. Let me stop there, Edith, and ask if anyone has any questions.
Yes, we do. We have a couple of great questions. Thank you for breaking for us. So one question is, would the pushing time during labor need to be decreased in someone who has IIH?
So no. So the pushing time is going to depend on the parity, if you will, of the patient. So if a patient does not have an epidural, according to American College of OBGYNs, they are still on the normal labor curve. If they are a prime or if it's their first baby, they can push for up to 4 hours with no epidural, 3 hours with one. If it is their second or more baby, they can push up to 3 hours or 2 without. So you don't have to say, oh, no, you can only push for an hour, you can only push for 2 hours because we're going to increase your intracranial pressure. That's not true. We do not change the rules for people with IIH. Okay, we don't change the rules. So the pushing time is the same, either 3 or 4 hours.
Wonderful. I think that is actually awesome that people can still have a normal pregnancy. And I'm assuming, and the other question to that was, if they have manifestation of papilledema, would that also play a role in the pushing, or it's the same statement you made?
So it plays a role in the pushing if it's extreme. So if you have somebody that has papilledema and evidence of severe increased intracranial pressure, then we say, hey, this is the person that needs intervention before they deliver. Okay, so either that person needs optic fenestration surgery before they deliver if it's severe, or if it's not severe and there's evidence of mild papilledema, then perhaps they need the adjustment of their acetazolamide dose. But we don't not allow them to push. What we would do is offer them an operative vaginal delivery so that they're not exerting as much pressure intracranially. So we would be doing either a forceps delivery or a vacuum delivery to try to assist with delivery of the baby, meaning putting traction on the baby's head while the mom pushes so that she will not exert as much intracranial pressure. Those are also people that I would say, hey, an epidural could relieve some of that intracranial pressure.